Welcome to Yodo. You only die once.
I'm Dr. Sarah Bohm.
And I'm Dr. Lisa Tartaglia. This session we're going to start out with a lovely quote that we found. There is an end to cure. There is no end to care.
So many people feel like they have a serious illness and they hear bad news and they feel like you don't care anymore because you can't cure me. And that's not true at all. Knowing what we're up against, providing education to the patients, that's our responsibility. That's our job. I always compare it to driving your car into the auto repair shop. You got a nail in the tire, and the tire, you can hear the air hissing out of it, and you make it there before your tire is flat, and your car's been blowing blue smoke and a funny sound coming out of the engine for a long time, but they repair the nail in the tire and they never say anything to you about the blue smoke or the funny sound. So then in a week when your car won't run anymore, now you're mad because they didn't tell you anything. You didn't give me any idea, any warning, that I should have even been, thinking about a new car. Well, cars are expensive and I know they're necessary and we have to have them, but I don't think they're nearly as important as your life. And even when cure is not available, we can still care, and we still do care. And we want to provide information so that you know that there are choices available to you even when you're facing serious illness.
Yeah, and I think it's so important to know that there are palliative specialists out in the community, because oftentimes people think of just the curative doctors that you're seeing in the hospital, and then there's hospice, and there's no in-between. But there really is an in-between. And that in-between started several years ago, and now it's becoming more known within the community, and there are specialists even in the hospital setting to help you.
More known within the healthcare system even, that there are other options. So most people have had a primary care provider that they go to between 1 and 5 times a year for their routine healthcare, their annual physical, follow up on their chronic medical issues. But many patients also have to have a specialist. They may have a heart specialist, they may have a lung specialist, they may have a cancer specialist. So many patients also have a specialist that deals specifically with one organ system that is not functioning optimally. I hate to use the word failure, when your heart is failing or your lungs are failing, because from the beginning it implies that you're not being successful. But if that organ system is not functioning optimally, you may need a specialist in that organ system. So you've got your primary care specialist, and you may have your organ system specialist, your cardiologist or your pulmonologist or your oncologist. Well, there's another specialty that is the palliative specialty, and that's part of what our specialty is palliative as well as hospice. And palliative medicine is available to anyone with serious illness.
Right, and it optimizes your quality of life by identifying your and assessing and treatment of your symptoms based on the illness, that serious illness that we're just trying to capture.
And where your specialist and your primary care physician are mostly caring for you and caring for your illness, the palliative specialist is also going to involve your family or your caregivers or your loved ones, because it's mind, body, spirit care for the patient as well as the caregiver. Because there's a tremendous burden on the patient, but there's also a tremendous burden on the caregiver.
Yeah, oftentimes it's so hard for the caregiver to express their burden because they're just trying to go through the motions to get their loved one from one appointment to the next appointment to the next appointment, thinking that there's going to be this, they're just putting band-aids, thinking they're going to fix this huge leak. And over time, it becomes so overwhelming to the caregivers, and they get left out because they're just the transport. They're just the person helping them get dressed in the morning, just the person giving them food, and they need to be part of the decision.
Yeah, part of that care team, and is another resource for us, for the physicians, to be able to have more information about how the patient really is doing. Because we want to optimize the quality of life, and we want to reduce the suffering that is coming from that disease process. And so, suffering, you can think of, well, that's easy. It's all about pain, and it's all about my bowels, and it's all about, my weakness or my dizziness or my shortness of breath. Suffering comes in many forms, and we want to reduce that suffering. Sometimes it's spiritual suffering. Sometimes it's psychosocial suffering. And so our team with palliative medicine also involves other disciplines
Mm-hmm.
to help that ease that suffering and help optimize that quality of life.
And sometimes it takes us knowing the whole picture of the patient in their home setting or through their caregiver to know where that suffering is coming from. We may think it's pain and we may start, titrating pain medication, but realize the underlying cause of that pain or suffering has something to do not with physical, but more of an emotional or even spiritual.
So we want to, as a team, the patient, their caregivers, and the physician, our LCSW, our licensed clinical social worker, our chaplain, our nurse, we want to, as a team, address, identify, assess, and come up with a treatment plan specifically for that patient. And so as Dr. T just said, sometimes the symptom that's manifested may be pain, but it may be something behind that that's actually causing that pain or causing the medicines not to work. I'm talking about easing a patient's symptoms and what's behind making those symptoms so severe.
Yeah, and I think also, like what Dr. Bone said, is it's individual treatment. Every patient is not treated the same way. As physicians, we have a logarithm of, okay, with somebody that has hypertension, this is the first line medication, the second line medication, blah, blah, blah. Same thing with diabetes, first line, second line. With palliative medicine, we treat individuals.
Right. We treat a person that is suffering from an illness. We don't just treat a disease process, because it's a person behind that disease process. And that's what sets us apart, because sometimes cure is not possible. Sometimes we have to, accept what we have, but we want to make it the best that we possibly can so that their quality of life and their daily function is optimized. What is serious illness? Can you that just sounds like such a broad thing.
Right. It's any illness that does not really have a cure per se, and it affects their symptomatology is shown in their daily activities of daily living, where they do not have the ability, like for example, let's just talk about heart disease, for example.
Okay.
Somebody with heart disease, they might be experiencing weakness or some shortness of breath and not able to golf anymore. Before they were able to golf 18 holes, now they can only do about 4 or 5 without having this symptom burden. So a serious illness, it can cause the symptom burden that will also cause a likelihood, if it was to progress, to shorten their life expectancy.
Looking at a serious illness, it's not necessarily somebody that's old. It could be for a young person, but it's a illness that limits their ability to have a good quality of life, that is a progressive illness that shortens their life.
And really what is our job is to try to understand what it is that the patient would like, what is their quality of life, because that differs from one person to another. Some patients are perfectly content with sitting at home watching Lifetime movies all day and Hallmark and eating their popcorn and just being able to go use the restroom.
No salt on the popcorn.
Yeah, no, of course, no salt on the popcorn. Or and just live in their bubble, where other patients want to be able to go to the movie theater and watch things.
So you have to decide for yourself what quality of life means. But patients who have serious illness and who have multiple symptoms actually can have an improved quality of life with decreased symptoms, decreased burden, less shortness of breath, less intestinal issues, and have a longer survival if they are involved with palliative care earlier in their disease process.
Yes.
So even the American Clinical Society of Oncology has deemed that within a few weeks of diagnosis of a malignancy, they would like a palliative care consult just to at least open the topic.
Because the reason being is it's very good for us to be proactive in symptom management with something like a disease trajectory of cancer, because we don't really know how each person will respond to the treatment, and then it will allow that person to be open and honest with their symptoms, and then also allow them to have a better quality of life because we're addressing them from the beginning. So in the event that their disease does take a progressive turn for the worse, they're already prepared because they've met with the clinical team. Because as we said, it's not just physicians, It's not just ARNPs, it's not just nurses. There are the licensed clinical social workers. Sometimes chaplains are involved, volunteers are involved. It's a whole interdisciplinary team, similar to hospice.
Yeah, so with that team, we can anticipate what's going to happen with this disease process and help the patients and families prepare for that and brace themselves for what might happen. And then maybe some of these symptoms we can alleviate before they become burdensome.
Yes. And I think it's so important to alleviate them before they become burdensome, and also to express anticipation of some of the illnesses, because that is what everyone knows. Okay, anybody that has, oh, I'm going to have chemo, first thing you think of is nausea. Well, people are waiting, or hair loss. And if you are working with the patients and the families before all this happens, it's not the fear of when it's going to happen. They're prepared for it. They're able to make better decisions. It's not as scary, because I think a lot of medicine can be scary, especially when you're faced with these serious illnesses, because you do not know the disease trajectory.
And there's so many facets to caring for a patient that you do need all these separate specialties and all these separate disciplines. So your oncologist is trying to manage your cancer treatment, or your heart specialist trying to manage your heart care. Your pulmonologist is worried about your lung function. And your primary care is kind of the captain of the ship, so to speak, and they're trying to make sure all of these things all work together, and that all the specialists are working together. And your palliative specialist is working for your symptom management to help you have the best quality of life that you possibly can.
So there is a difference between palliative care versus hospice care. With hospice care, there is a prognosis of 6 months or less. And the disease, if it ran its natural course, the patient will pass within 6 months. Palliative care, there is not that same disease trajectory. There does not have to be a terminality of illness. It is just, as we discussed, these serious illnesses. And these serious illnesses cause symptom burden, and that's what a palliative team addresses.
So palliative care is a newer specialty, but there are just not very many palliative care teams that are out there right now. There are very few palliative physicians in the United States. Most palliative care is provided by your specialist or by your primary care, but it's extra duty, extra work for them, because they're really focused on or honed in on one thing. And then when they start talking about spiritual needs, when they start talking about suffering, when they start talking about symptom management, many of them will actually say, well, today that's all of the time that I have for you today, so I really need for you to come back so we can allot another time slot for you, because physician time is really kind of short right now. There's a real physician need, and there are not very many palliative care specialists available at this time.
When I was in training, this division of medicine didn't even exist.
So it's a newer specialty, and there are not a lot of palliative care physicians available, and many of the palliative care physicians that are available are being snapped up across the country by hospital systems and by hospice organizations, because they want that palliative hospice trained physician on their staff to try to help patients manage these symptoms.
And it will help increase their quality of life. And then obviously for the hospital system, it will cut down costs, because once symptoms burden is managed, their likelihood of returning to the hospital is slim.
Is less, because patients get in a crisis or they become afraid, and so the first place they go is back to the hospital. Many patients who go to the hospital are not happy about going to the hospital. There are a lot of patients who are in the hospital that's not the place where they really want to be, but they don't feel like they're getting the care they need. They're not getting the symptoms managed to be able to stay in their home, and they don't know how to address those needs. They don't know how to take care of themselves, and that's where the palliative team also can help. They can help them understand their symptoms, and they can help them know who to contact and at what point in your care do you need to be contacted, because it's another team assessing the patient and providing that care.
Yeah, currently I work for a home-based palliative team. My region is in Florida, which is where I reside. And I find it so incredible when we just communicate back to the PCP. For example, I had a patient recently that has been having a lot of symptom burden due to a cardiac illness. He's very young, So it's not somebody that you would think would be prepared to be dying. He's definitely not prepared. He just recently was married. And basically what, in summary, what happened is we finally reached out to the PCP, and the PCP was so grateful because we're able to give him a snapshot of what's going on in the home. He was not being communicated to with the hospital team because there's a division of a hospitalist versus the PCP taking care of the patient. And now we're able to make leadway together on to direct his care, which will hopefully prevent further rehospitalizations and allow him to be at home, at peace, and having his symptom burden managed at home.
Yeah.
So I find that this is innovative. There's not a lot of insurance that pays for this type of team, but this is the future of medicine.
Yeah. We want to be able to help manage those symptoms so patients can be where they want to be and have the highest quality of life, rather than spending day after day or week after week in the hospital, because you tend to get weaker while you're at the hospital. So we want you to stay at home. We want you to be at home. We want you to be functional and have your symptoms managed. The last bullet point I want to bring up is the palliative physician team does not replace your PCP, and they don't replace your specialist. It's an additional physician to help care for you. So they're not going to take you away from your other physicians. You're not going to stop seeing those other physicians because they're not going to replace your other specialists or your primary care. This is an addition. I think that's it for us to talk about what palliative care is and how it's different from hospice and how it can help different individuals with serious illness.
To meet patients where they're at and to help them in their own disease trajectory. And thank you so much, and we look forward to seeing you again.
We'll
Please
see you real
leave us
soon. Thank you.
comments. Bye.